Muchas gracias a todos por acompañarnos el día de hoy. Bienvenidos a nuestro webinar de Cochrane Colombia, nuestro primero del año. Como siempre, ustedes saben que este es un espacio para compartir. Hoy tenemos como invitado al doctor Gordon Guyot. Muchas gracias por aceptar participar en este webinar. El moderador de esta sesión y la persona que va a estar coordinando el webinar es el doctor Iván Flores de la Universidad de Antioquia. Muchas gracias por la gestión. Gordon, good morning. Thank you for your time. Welcome to Cochrane, Colombia.
Thank you.
Bueno, entonces podemos empezar. Doctor Iván, muchas gracias a todos por acompañarnos el día de hoy.
Gracias, doctora Mary. La verdad es que no hay mucho que presentar al doctor Gordon, lo conoce todos los que trabajamos en esta área. Gordon fue mi profesor, ahora mi colega y amigo, y es un placer tenerlo aquí nuevamente. Es médico internista y profesor distinguido de la Universidad de McMaster University en Hamilton, en Canadá, y va a hablar hoy de core grade y va a explicar las bases de este abordaje. Y la idea, como siempre saben, la idea es hacer una presentación y posterior a la presentación resolver preguntas que tengan. La, Gordon ha traído una serie de diapositivas interactivas para dar algunas respuestas con algunas encuestas, así que les pedimos que nos ayuden respondiendo las preguntas. Inmediatamente él hagamos la encuesta, no vamos a tener más de 10 segundos para las respuestas, son preguntas muy sencillas, es más para orientar y contextualizar al público sobre los temas que él está abordando, para que estén atentos entonces a la encuesta para darle respuesta cuando se ocurra. Thank you so much, Gordon. Pleasure to have you here as my mentor, friend, and colleague. Always a pleasure to work with you and present you this in this webinar for Cochrane Colombia. You have people from mostly from Colombia, but there might be people from other places around Latin America here or many other places. So it's all yours. If you are able to present now the slides, it will be great so we can verify that everything looks good.
Thanks very much. Great pleasure to be here.
Yeah.
And uh, these slides should be appearing momentarily. I thought they would be appearing right now, but they will appear, I'm sure, in just a second. There we are. And we're now going to be in slide presentation mode, which it takes a moment to get right. There we go. So now you should see my full screen.
Yep.
So recent progress in evidence-based medicine, talking about core grade. Evidence-based medicine is about delivering the best evidence-based care. Guidelines have become key tools for evidence-based medicine. But for guidelines to work well, the guidelines have to be able to tell their audience about the certainty of the evidence and the strength of the recommendations. GRADE offers approaches to guidelines for both parts, deciding on the certainty of the evidence and moving from evidence to recommendations. The GRADE approach has become very successful. So World Health Organization is one of the 120 organizations that have adopted GRADE. Major American organizations like the American Thoracic Society, American College of Physicians, the NHS in Britain, and perhaps most relevant to this audience, the Cochrane collaboration. So the Cochrane collaboration insists now that people use GRADE when they do Cochrane reviews, a very important decision on the basis of the Cochrane collaboration. So very successful, except now there's a problem. GRADE has become too complicated. There's a series in the JCE, Journal of Clinical Epidemiology, now the latest papers appearing in the Annals of Internal Medicine, which is official guidance from the GRADE Working Group. 44 papers and still going. There are other papers from GRADE authorities, including the papers that I'm going to tell you about today, that also provide guidance. Some of the earlier guidance has now become obsolete and replaced by new guidance, but it's hard to identify and integrate it. And much of the recent guidance, we think, people find excessively complex. So what can we do about it? What's the solution to this problem of GRADE becoming too complicated? The solution, we think, is core grade. It's the essentials of grade, all you need to apply grade for paired comparisons of interventions versus alternatives. It deals with both systematic reviews and moving from certainty and moving from evidence to recommendations. It appeared in 7 papers on a weekly basis between April and June in last year. So here is an overview of the core grade process. On the left side is the systematic review process, which you're all quite familiar with, and on the right side, the guideline. So as you well know, you will start the grade process of rating certainty of evidence by finding your PICO and choosing your outcomes. Outcomes we will think which are critical, which are important, and which are unimportant. Subsequently, you move on only with the ones that are important or critical. And you get the estimates of effect. And what grade provides is not only a way to get at the estimates of effect, but to rate their certainty as high, moderate, low, or very low. Well, at the end of that systematic review process, if it is done for a guideline, you then will send the results of your systematic review over to the guideline panel in the right part of this slide. The guideline panel will consider what their perspective is. Is it an individual patient perspective, or is it a population, public health, or societal perspective? If it is an individual patient perspective or a societal perspective, they will consider the magnitude of the benefits and harms. They will look at the certainty of the evidence, and they will look at patient values and preferences. If they're taking just an individual perspective, and this is one of the things that core grade emphasizes, they may stop there. They may not need to consider other aspects of the evidence to decision framework. If they take a public health perspective, on the other hand, for sure, they're going to have to look at these additional grade elements of the evidence, the decision framework, resources, feasibility, acceptability, and equity. After making their consideration, they will come up with recommendations that are strong or weak, either for or against the intervention. So that's the overview of the grade process of systematic reviews and guidelines that end up with strong or conditional or weak recommendations for intervention or comparator. So target of the certainty rating. In getting on toward 10 years ago, grade changed what we were thinking about what we call the target of a certainty rating. In what is it in which we are rating our certainty? And what we decided and what core grade says is, we're rating our certainty that truth lies on one or the other side of a threshold. And the more complicated grade identifies 4 different thresholds. Those 4 thresholds are the null effect, the minimally important difference, the moderate effect threshold, and the large effect threshold. One of the simplifications of the core grade approach is you don't have to worry about your moderate and large effect thresholds and deciding exactly what they are, but you do have to pay attention to that MID, otherwise called the small effect threshold. And so we're going to focus on how we use that MID for rating our certainty of the evidence. So one of the things we're going to do here is show you some polls. And I should have said before that I do not mind. In fact, I encourage interruptions along the way. So if you have any questions or something I say is not clear, you can interrupt either by speaking up, or Yvonne, if you want to watch the chat for me, then if anybody has a question in their chat, I'm happy to interrupt to answer that question. But here you have 3 different thresholds. One is the no effect threshold. Now, we then have minimally important differences. So let's take the outcome of mortality. What is the smallest important difference? You're in a guideline panel. What is the smallest possible difference in mortality? Well, as it turns out, how do patients feel about that? the evidence is very limited. And so guideline panels actually may choose different MIDs. And we're just in the midst of completing a systematic survey of what MIDs guideline panels choose when they are looking at mortality. And it's anywhere from 3 in 1,000. Some guideline panels say patients will think anything over 3 in 1,000 is important. Other guideline panels say, no, no, that's not right. It's not important unless it's 20 in 1,000. So MID1 might represent a panel that says only anything more than 3 in 1,000 is important. And MID2 may say, no, no, no. 20 in 1,000 has to be at least 2% before patients think it's important. So we can always rate our certainty in a non-zero effect. So that's one of the things we can say. How certain are we that there is a true non-zero treatment effect? And systematic reviews often do that. We've just done a survey of systematic reviews. When they choose their certainty of evidence, half of them tend to choose certainty in a non-zero effect. However, when you get to a guideline panel and you're making value and preference judgments, you should decide on what the minimally important difference is and decide on rating your certainty about the minimally important difference. So we're going to do our first polls here. And what I'm going to want you to do is just answer quickly. Don't worry too much about whether you're right or wrong. The polls make things more fun, but we need to move them along. So quickly, when I put the poll, offer your answer. So the black dot represents the point estimate. Think of the panel that has chosen MID1. 3 in 1,000. Anything more than 3 in 1,000 is important. Is it appropriate with that point estimate and MID1 to rate your certainty in an important effect? Yes or no? Okay, that's the question to you. Taking MID1 and that point estimate, is it appropriate to rate your certainty in an important effect? Yes or no?
Fabián,
So we have the poll up. I see the poll. So far, no answers, but say yes, it's appropriate, or no, it's not appropriate. And one person so far says no. But what about the other 25 or 30 of you? Okay. Most people say rating your certainty in an important effect. Oh, now we're getting a split. Okay. Now we're also seeing it appear, the next question, certainty in an unimportant effect. So I'm not quite sure what's going on here, but well, let's take it both. I was going to then, okay, so you're answering for certainty. Well, so most people say the majority say it's appropriate to rate your certainty in an important effect and certainty and you're rating the other one well. Well, it can't be both. So let's end the poll, please. Okay, can we get it off this? Let's see, do I have to get it off the screen? Yes, I do. Okay, the point estimate is greater than the minimally important difference. Okay, so that means it's appropriate to rate our certainty in an important effect because the point estimate suggests just that. The point estimate is greater than MID1, so it suggests an important effect. So it would not be appropriate to rate your certainty in an unimportant effect. But, and I think we'll skip the poll for the second one, the way that worked out. If we have MID2, then, which would be, say, 20 in 1,000, as some panels have done, now the point estimate is less than our MID. Now it is inappropriate to rate your certainty in an important effect because the point estimate suggests an unimportant effect. Is it appropriate to rate your certainty in an unimportant effect? Yes, because the point estimate is less than your MID. So in deciding your target of your certainty rating, the way you do it is look at the relationship between your point estimate and your MID. If your point estimate is greater than your MID, you're rating your certainty in an important effect. If your point estimate is less than the MID, you are rating your certainty in an unimportant effect. So here is the overall process of grade when we rate our certainty of the evidence. We've just learned that we first have, before we do anything else, we have to set our target of the certainty rating. Our target can be a non-zero effect or in core grade, a minimally important difference. Well, in grade, the randomized trials start as high certainty in grades high, moderate, low, and very low categorization. But as I'm sure you well know, there are a number of reasons where we rate down our certainty for risk of bias, imprecision, indirectness, inconsistency, or publication bias. Non-randomized studies of interventions or observational studies start as low, but sometimes, particularly with a large effect, we can rate up, or we may rate down again from low to very low for any of those characteristics. We'll talk now a little bit more about core grades approach to making these ratings. One of the important things that core grade points out that was not emphasized in prior grade writings is that certainty of evidence is a continuum. So we break it into four categories, but it is a continuum. And also, we break our ratings for individual domains. So consider risk of bias. We're going to say risk of bias is not serious, serious, or very serious. Serious, we're going to rate down 1. Very serious, we're going to rate down 2. But it's actually a continuum. And sometimes things are at the border between not serious and serious. And we struggle to decide, should we rate down or not? Sometimes it may be in the border between serious and very serious, rating down 1 and rating down 2. And when you're using core grade, you want to bear in mind that it is a continuum. And it's the same for ratings. Your final rating of your certainty in the evidence is very low, low, moderate, or high. Again, there may be close calls. It's a continuum, and there may be close calls between adjacent categories, and that is worth keeping in mind. So we have another set of questions now about rating imprecision. And these questions we're going to ask focus on your understanding of the target of the certainty rating. So let's take A. You see there the point estimate and the confidence interval. The solid line is a risk difference of 0. In other words, no difference between intervention and comparator. The broken line is the minimally important difference. So one thing in A we can do is rate our certainty in a non-zero effect. If we were rating our certainty in a non-zero effect, would we rate down for imprecision, yes or no? So we have a poll for this. Our target of certainty rating is a non-zero effect. Are we going to rate down for imprecision? Yes or no?
Fabian?
Don't see the poll up yet. There's the poll. Okay, so I was hoping for one question at a time here, but let's do the first one. So rating a non-zero effect, just answer once, yes or no, rate down for imprecision. No answers yet. That's it. They're coming in. Okay. One person says no. Now, this confuses me with two questions on the same. Uh,
Yeah, let's wait for people answering the number 1.
Just number one. Just number one. We're rating our certainty in a non-zero effect. And everybody so far is saying no, and everybody so far is right. So I don't want to spend too much time. One person says yes. Okay. Um, the answer, okay, this isn't working so well. Okay, I'm just going to tell you what I'm going to do. I'm going to ask you the questions. I want you to think carefully. I'll give you a minute to think about it, the answers. We'll may try some formal polls later, but we'll do without the polls for now. Okay, so A, almost everybody who weighed in said we don't rate down for imprecision, and that's right. Why not? Because the entire confidence interval is to the left of our threshold of no effect. Okay? Doesn't cross, we don't rate down. What if in A we were rating our certainty in an important effect? Would we rate down for imprecision? Think about it for a second. The answer is we would not rate down for imprecision because the entire confidence interval is to the left of our threshold of the minimally important difference. What about B? If we are rating our certainty in a non-zero effect, would we rate down for imprecision? Yes or no? What do you think? Answer is no, we would not. Why? Because the confidence interval does not cross our threshold of no effect. The entire confidence interval is to the left of our threshold of no effect. And at least as far as imprecision is concerned, we can be confident that there is an effect. What about if our threshold we have chosen is the MID? Are we going to rate down for imprecision? Yes or no? What do you think? Answer is yes. Why? Because now our confidence interval crosses our threshold of the MID, and it's as far as the confidence interval is concerned, maybe there's an important effect, but maybe there is an unimportant effect. What about C? C, if our threshold is the null, we're rating our certainty in a non-zero effect. Will we rate down for imprecision? What do you think? And the answer is yes, we will rate down for imprecision. Why? Because the confidence interval crosses our threshold. It includes a difference, and it includes a difference on one side, difference on the other side, and no difference at all. So it's crossing our threshold of no difference. And since it's crossing our threshold of no difference, we don't know whether there's an effect or not, and we're going to rate down for imprecision. What if we're rating our certainty relative to the MID? Well, we're going to be rating our certainty in an unimportant effect because the confidence interval is to the right. It's actually over on the harm, or the point estimate is to the right. It's actually over on the harm side. But we are not going to rate down for imprecision because the confidence interval doesn't cross our threshold of the MID. In D, we're going to rate our certainty. If we rate our certainty relative to the null, we're going to rate down for imprecision because it crosses our threshold of the null. And we're going to rate down for imprecision with respect to the MID. We are going to rate our certainty in an important effect because the point estimate is greater than the MID. And we're going to rate down for imprecision because our confidence interval crosses our threshold. Bottom lines, you pick one of two thresholds, the null, where you're rating your certainty in a non-zero effect, or the MID, when you're rating your certainty in an important or unimportant effect. If the confidence interval crosses whatever threshold you've chosen, the null or the MID, you're going to rate down for imprecision. If the confidence interval does not cross your threshold, you are not going to rate down for imprecision. It is possible to rate down twice for imprecision. When would that happen? This happens to be a point estimate and confidence interval for the effect of thyroid hormone treatment versus no treatment in cardiovascular events for patients with subclinical hypothyroidism. The red lines represent our minimally important difference. And what you see here is that the point estimate is in the range of an unimportant effect. So we are going to be rating our certainty in an unimportant effect because that's where the point estimate is. It's between our two important effects, so it's an unimportant effect. But we see the confidence interval crosses the threshold of an important benefit and it crosses the threshold of an important harm. And when it crosses those two thresholds, both an important benefit and an important harm, we think that it's a situation in which you consider rating down twice for imprecision. There's an additional problem, unfortunately, with imprecision. Our main decision is about crossing our thresholds, but sometimes we see a very large effect with a relatively small number of patients, and we are skeptical. And the answer that GRADE provides to that is the optimal information size, which is the number of patients, if you were doing a conventional sample size calculation, with a modest delta that you would need. And here's an example from fluoroquinolone prophylaxis in neutropenia and its effect on infection-related mortality. Well, as it turns out, there are a relatively small number of patients, around 1,000 in the trials that you see there, and quite a very small number of events. You see, for instance, in the quinolones, you see a lot where there are 0 events, and the total number of events is only 5, 6, 8 events. Okay, very few events. So, as a result, it looks like your point estimate and confidence interval are fine. Mortality is an important, very important outcome, and fluoroquinolone prophylaxis has limited adverse effects. Looks like you're getting an important effect on reduction in mortality. But if you do your sample size calculation of the optimal information size, you would find you need 6,000 patients when there's only 1,000 patients in this sample. As a result, although it looks like things are precise enough with respect to our threshold, confidence interval is not crossing the threshold, we're going to be rating down because a big effect size, a 62% relative risk reduction, and it fails the optimal information size. Bottom signs of precision. You need a target of the certainty rating. You look at the upper and lower boundaries of the confidence intervals. If it crosses the threshold, you rate down. If it crosses two thresholds, an important benefit and an important harm, you will consider rating down twice. If the effect is large, a relative risk reduction of greater than 30%, you may look again and say, really, did we have enough patients, and apply the optimal information size. If it meets optimal information size, you're okay. If it doesn't, you would rate down under these circumstances for imprecision. Okay, moving now from imprecision to risk of bias. Cochrane suggests risk of bias 2. Risk of bias 2, many people find too complicated. The technical language has changed. It's difficult to figure out where blinding is in the risk of bias 2, the way they characterize it, and it has a number of steps to it. So because core grade says, let's keep it as simple as possible, we have developed a new instrument called Robust RCT, published in the BMJ last year. It has 3 key elements to it: sequence generation, concealment, blinding 4 elements, 3 blinding, and loss to follow-up, and 8 optional items, which you often won't use at all because they're infrequent, poor reporting, or the judgment is difficult. So one example of one of these optional items is the outcome measurement data was collected differently in the intervention and control. Infrequently a problem and may be difficult to judge, so that ends up as a optional item. Similarly, trials stopped early for benefit. If it is thought for benefit, it may well be an overestimate of the treatment effect, but that seldom happens. So, what about cohort studies? The Cochrane approach suggests using Robin's eye. I don't know if any of you have tried it, but Robin's eye to me is a disaster. It is much too complicated. It's gone off the rails in terms of complication. So Clarity suggests with an alternative, a modified sort of each core grade suggests a alternative. Our group at McMaster, the Clarity group, has modified the Ottawa Newcastle instrument and has the items that you see below there, and is much, much, much simpler than Robin's eye. And again, core grade is trying to make it maintain rigor while keeping it as simple as possible. Directness, populations, older, sicker, or more comorbidity than your target PICO population. Interventions, you may be thinking of surgeons in the community, and the trials may have used elite surgeons. There you would have indirectness in the interventions. Standard care may differ in one circumstance or another, and that would lead to indirectness in the comparators. And the most serious problem, perhaps, of indirectness is when people use surrogate outcomes like blood glucose in diabetes instead of patient-important outcomes like cardiovascular events or peripheral neuropathy. So if you have a surrogate outcome that is being used, you have major problems of indirectness. We'll move to consistency, and now we're going to try the polls again, see if they work better this time. Here are 4 studies and the pooled estimate from these 4 studies. And the question is, would you rate down for inconsistency? Do you see problems there with inconsistency? So the poll, I hope, will be a yes, no, and it will say yes, rate down for inconsistency, or no, do not rate down for inconsistency. Let's put up the poll.
So the poll here, I think, is about the I-square, Gordon, just to remind you.
Oh, it's just this one. We didn't. Okay. Thanks very much. I thought we had one for this too. Well, in that case,
We have the poll with the potential I-squares.
yeah, okay, we'll get to that then. Sorry, I thought we also had a poll for this. Think about it then. Would you rate down for consistency, or would you not rate down for consistency with this result? And the answer is no, you would not rate down for inconsistency. Why? Because the point estimates are very similar and the confidence intervals are widely overlapping. And now I'm just, okay. Now, what about this one? Would you rate down for inconsistency? Think about it for a second. And the answer is yes, you would rate down for inconsistency because the point estimates of the 2 estimates on the left are very different from the point estimates of the 2 on the right. Not only that, but the confidence intervals are non-overlapping. So our 2 things we look at when we decide whether to rate down for inconsistency are the point estimates similar or different? Are the confidence intervals overlapping or non-overlapping? And I-squared is another consideration, a statistical consideration that we might also look at as well. 0%, I-squared of 0%, no worries. As I-squared gets bigger and bigger, we have more concerns. And so, as Yvonne has just reminded me, we have a poll for the I-squared here. We want you to guess at what the I-squared is. And we have four options, I believe, as to what the I squared might be. And if we can put the poll up, we will find out what you think of with the I squared.
Fabián, por favor.
Okay, so the options are, what is the I squared? Is it going to be 0, 25%, 50, 75, or 95%? What do you think? Okay, we are getting some 0 or 25%. Some people say 75%. Okay, now we have more coming in for 0. Still to see, somebody thinks it's 95%. Okay, so quite variable. The majority are at either 0 or 25%, but some more. The answer is 0. Okay, and the answer is 0 because the results are very, very similar. As a matter of fact, have you ever seen a forest plot with results of the four of studies as similar as this? They're between zero point 0.7 relative risks of between 0.71 and 0.76. Very, 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 very similar. And when the point estimates are very similar and the confidence interval are widely overlapping, then you're going to see a very low I squared. And in this case, the confidence intervals are so overlapping, the I squared is 0. What about this one? Same question. What do you think the I squared is in this case? Same response options.
Fabián, por favor. Fabián, eso, perfecto. No, esa es la anterior a eso. Gracias.
Okay, there we have. Okay, so what's the I squared now? One person thinks it's 50%. We're up to half the people think it's 50%, some 75%, some 95%. Okay. That's as the results come in, that's about what it's half the people approximately think it's 50%. And then you have more or less the other half thinking that it's either 75 or 100%. As it turns out, the main driver of the I squared is overlap in the confidence intervals. And here there is zero overlap between the confidence intervals on the left and the confidence intervals on the right. And as a result, I squared is 89%. So here with these extreme non-overlap of the confidence intervals, very high I squared. Now, I'm going to ask another question about inconsistency, so we can close out that. It's still appearing on my screen, that prior poll. Now, this emphasizes how our target of our certainty rating. The I squared keeps appearing on my screen. This emphasizes the target of the certainty rating, and it's important. So this is about local anesthesia after knee replacement, and does it reduce pain? And it's measured on a visual analog scale. The solid line is no difference, no benefit with the local pain infiltration, and on the left side, and the dotted line is the minimally important difference, which is 10 centimeters or 10 millimeters on a 100 millimeter line. Okay, let us say the target of our certainty rating is no effect. Okay, so we're rating our certainty in a non-zero effect. I think we have a poll for this. Is that right, Yvonne?
Let me check. Fabián.
Okay, well, there we go.
Yeah.
Okay, So when now we have, tell you what, it's not working when you have two questions on the same poll. So we will just get people to think about it. So forget about the poll for this. Okay, so let's say the target of your certainty rating is a non-zero effect. Are you going to rate down for inconsistency or not? And the answer is, think about it, the answer is no. Why not? Because all of the point estimates but one are to the left of the null, and most of the confidence of the intervals don't even overlap the null. So the results look very consistent, saying there's a non-zero effect. Note the I squared in the bottom left corner. The I squared here is almost 95%. So despite a huge I squared, we do not have problems with inconsistency when we're rating our certainty in a non-zero effect, because all the point estimates suggest a non-zero effect, and most of the confidence intervals don't even overlap a non-zero effect. Let us say, on the other hand, we decided to rate our certainty in an important effect. You can see the triangle at the bottom. It shows that the point estimate is above the MID. So now we're rating our certainty in an important effect because the point estimate is greater than the MID. And now are we going to rate down for inconsistency? Yes, we are. Why? Because now half the point estimates are to the right of the MID, and half the point estimates are to the left of the MID, and you have non-overlapping confidence intervals between some on the right of the MID and some on the left of the MID. So in this case, now the I squared kind of makes sense for this one because we are going to rate down for inconsistency. So the point of this is that whether you rate down for inconsistency or not is going to depend on whether your target of your certainty rate is going to depend on your target of certainty rating. And in this one, it's crucial. Target of the certainty rating is a non-zero effect. No problems with inconsistency. Target of the certainty rating is an important difference. Big problems with inconsistency. So what happens if you get this result? What looks like big problems with inconsistency. What would we hope that our systematic reviewers would do? And the answer is look for explanations of inconsistency. Could it have been differences in patients, interventions, comparators, outcomes, or could it be risk of bias that explains the difference? So we would want our reviewers to look. What if none of those explain? What will we do? We will rate down our certainty for inconsistency. If we do think maybe one of them explains, we must test, is this really a credible explanation? This is Stefan Schandelmeyer, who did a PhD with me a few years ago, and the result of his PhD was an instrument for assessing the credibility of effect modification analysis, which he decided to call Iceman. So Iceman now is a formally developed instrument for rating the credibility of subgroup effects. It works for randomized trials, and for Cochrane, you're all going to be doing meta-analyses, and it has criteria for meta-analyses. At the end, at the bottom, you see a approach modeled on grade. You know, grade has high, moderate, low, and very low certainty. Here it's high, moderate, low, and very low credibility of the subgroup effect on the basis of the questions. And you'll notice that above the four categories is a line emphasizing that it's a continuum. You may be on the threshold, on the cusp between high and moderate, moderate or low, and low or very low. And that's quite different than if you're at the ends of one of the criteria. So one of the things that we like about core grade is an algorithmic or flowchart approach to making the ratings. And here's one for consistency. You start with the question, are there important difference in the point estimates and limited overlap of the confidence intervals? No, point estimates are similar, lots of overlap in the confidence intervals. You don't rate down. If the answer is yes, you evaluate the point estimates in relation to the chosen threshold. The majority are on one side of the threshold, like we saw in the pain example, where if you chose your thresholds of the threshold of the null, everything was to the left of the null, you do not rate down. On the other hand, as happened with the MID, if the point estimates, if there are a substantial proportion on one side or the other, you will rate down, but you will look first. Can you explain the inconsistency by a subgroup analysis? No, you can't explain it. You rate down. Yes, you explain it. You present results separately for each subgroup. So that's an algorithm for dealing with inconsistency. What do you do? What can raise the confidence? Everybody used to do badly. Now people do well. Things like insulin for diabetic ketoacidosis, hip replacement, or dialysis for renal failure. And under those circumstances, you may rate up for inconsistency, or sorry, for rate up for a large effect. So you then, with grade, create summary of findings tables where for each outcome you present the relative effects, the absolute effects, the certainty, and a plain language summary. You then move from your summary of the evidence to recommendations, a strong recommendation where the benefits clearly outweigh the harms and burdens, or vice versa. What can move you from a strong recommendation to a weak or conditional recommendation? If the balance between desirable and undesirable outcomes is close, then you may move from a strong to a conditional recommendation. If the quality of the evidence is low, you will move from a strong to a conditional recommendation. If values and preferences are uncertain or very variable between patients, you're much more likely to make a conditional recommendation. Those are in core grade, tells us that if you're taking an individual perspective or a societally or population perspective, you're always going to carefully consider those three. With an individual patient perspective, the others, cost, equity, acceptability, or feasibility, may be minimally irrelevant, and so you're not going to pay too much attention. If you take a societal or public health perspective, they will be important. So uh, in the core grade approach, it does not have any large checklist for you to fill out and decide for every outcome whether the effect is minimal, small, moderate, or large. No, it's a much simpler approach illustrated here for influenza, where you have narrative summaries for each of the evidence to decision frameworks, and that's how you're going to present it to the panel and make your decision. Significance of a strong and weak or conditional recommendation. Strong recommendation, all or almost all patients would make the same choice. A weak or conditional, it varies appreciably. Implications for interaction with the patient. A strong, no need for extensive shared decision making. You tell the patient, this is what I think is best for you and why. A weak or conditional recommendation, you need shared decision making to ensure that the decision is in line with patient values and preferences. Decision aid, strong, probably not, you don't need it. A weak or conditional, if there's a decision available, you'll want to use it. In conclusion, grade has been a huge advance, and Cochrane rightly insists that systematic reviewers for Cochrane use grade. It has also been a big advance in moving from evidence to recommendations. Grade, however, has become too complicated and difficult to navigate. core grade in those 7 articles in the BMJ is all you need. What is, we think, wonderful about it is all you need. Once you go to those 7 articles, you needn't look elsewhere for guidance in how to apply grade when looking at an intervention versus a comparator. I have left a few minutes for questions, which I would be happy to take. So I stop sharing, and if anybody has a question or comment or reflection that you would like to share, I would be more than happy to address it.
Thank you so much, Gordon. Very concise to cover a lot of content in very short time. Estamos abiertos para preguntas. Si alguien tiene preguntas, por favor, pónganlas en el chat y podemos pasarlas aquí a Gordon. Mientras tanto, voy a hacer una pregunta a Gordon y mientras vemos que alguien agrega alguna pregunta. Gordon, what would you tell people that will be interested in training, getting training in grade, if they think that they have been applying the usual traditional long approach of grade, and if people who are confident they've been using grade, do they need additional training to support to apply core grade, or do you think that people who have experience would have just reading the papers and going there and
So, core grade is the essentials of grade. If someone feels really comfortable with grade as it exists, if you've read all of the 50 articles and processed them, and you've seen where grade guidance has changed over time, no problem. You are set. If you have some doubts about whether you have kept up, you find some of the new guidance complicated. You have, when you fill out the full evidence to decision and answer on a panel, you find it tedious or complicated, then any of those reasons you will want to look to core grade. We believe that we have done a good job, and the feedback so far is that we have. And just as reading the previous grade papers was helpful, got you most of the way we hoped, reading these, it's the same. One of the things we do is we have frequently asked questions for grade. You can share with everybody, Yvonne, my email is simple, guide@mcmaster.ca. If you have questions about core grade, anyone in the world can send me questions about core grade, and I am happy to answer. Clearly, we have run a workshop in core grade. You want to go further and deeper and clarify your understandings of the stuff that I presented here. Okay, you've got clearly an overview of core grade in this presentation. Clearly, discussions with your colleagues or taking or coming to a course will deepen it. But we believe you read the 7 papers. If you've used grade and now you read the 7 papers, you will be able to use core grade.
Excelente. Por favor, les recuerdo preguntas en el chat por si alguien quiere hacer alguna pregunta. Gordon, would you, in terms of web page or platform that will support the application of core grade, would be the usual approach that we use, Grade Pro, Magic, among other things, or there is something special for core grade? What would be your suggestion for people who are using these platforms?
We think that it is, people have their different preferences. I clearly am very associated with making grade the irresistible choice, Magic. And so I would recommend the Magic platform but this is just neither platform tells you what to do. It just gives a nice structure to facilitate it. So you can make your judgments and you do your summary of findings table without using either of them. It doesn't tell you how to apply grade. All it does is facilitate a structured approach to ending up with your summary of findings table. So that should be clear. But as it turns out, in terms of a website, we are in the midst right now of creating a website for core grade. And so we hope in the next couple of months, you are going to see a website for core grade, which will include a nicer. When you put it in a journal, there are constraints. When you put it on a website, you get rid of those constraints. The presentation is even nicer. And we think the presentations in the BMJ articles were pretty good. The presentations on the website are going to be even nicer. And it's going to include in the same website robust RCT, which I told you is our recommended instrument for risk of bias assessment, and Iceman, our recommended instrument for deciding on the credibility of subgroup analysis, and a tool called Judge, which one of the big advances we think on core grade is the algorithms. I showed you one of them. People are finding them very helpful. And Judge is a structured approach to an educational tool, really, that takes you through the algorithms, helps you with the algorithms, applying the algorithms for the judgments of risk of bias, inconsistency, indirectness, and so on.
Awesome. Thank you, Gordon. There is a question about core grade. Would core grade be a good tool to evaluate the real world evidence studies?
Absolutely. So one of the unfortunate mischaracterizations of evidence-based medicine and grade is it's just about randomized trials. It is not. Now, I don't like personally the term real world evidence because it somehow tends to imply that randomized trials don't happen in the real world. They do, as far as I can tell, happen in the real world. But when we're talking about real world evidence, we are talking about observational studies, non-randomized studies of interventions, and in fact, for the way many people use the term, it's not even as good as most observational studies because it comes from administrative databases, which has data you cannot trust. So, but nevertheless, it has its limitations. Those studies are going to start as low certainty evidence in the core grade approach, and they may, if you can't do, for instance, appropriate adjustment because your administrative database hasn't measured the variables that you need to adjust for or hasn't measured them accurately, you might end up with very low certainty evidence. But clearly, core grade tells you how to, just as it tells you how to deal with randomized trials, it tells you how to deal with non-randomized studies as well.
Thank you. There is a very specific question. I'm going to try to replicate it, Gordon, about the certainty. When the certainty of the evidence is low, but the values, cost, feasibility really strongly favor the intervention, what would be your threshold, your personal threshold to go for a strong recommendation? Or do you think that that shouldn't happen never in grade? Thank you so much.
So you're talking about low certainty evidence about a critical outcome. So you are uncertain whether things seem to favor the intervention, but you're uncertain whether there's an important benefit. Maybe there is, maybe there isn't. And all our treatments have downsides. So you are going to, our criterion for a strong recommendation is that everybody or almost every informed patient would make the same choice. So here you are talking to the patient. Oh, it looks like it might work and it looks like it's low cost. And can't remember what all those things you said. It kind of looks good, but sorry, we're not too sure. Maybe it works. Maybe it has an important effect. Maybe it doesn't. And always it will have downsides. If you say that to a patient, do you think everybody or almost everybody would say, bring it on? I don't think so. Maybe most people would say, bring it on, but if somebody would say, you mean, doctor, you're not sure it works? Oh, we got low certainty evidence. Yeah, I'm not sure it works. And it has adverse effects? Yeah, it does have adverse effects. Nah, no, thank you. Okay. So in the situation that is depicted, I think there would be variability in choice according to patient values and preferences, and that would warrant a weaker conditional recommendation.
There is another question, Gordon. I will take a couple more minutes for this question. I think it's the last one in the chat. In different scenarios in which there is high heterogeneity, that means an I squared that is high, but the global effect is consistent in the direction of the effect on the intervention and is clinically important. When do you decide not to write down for inconsistency versus exploring subgroup analysis? And what weight you will give to Iceman in that decisions?
Okay, let us say that the that your point estimates, say your point estimates are all on the side of an important effect, and the confidence intervals, many of them don't overlap the threshold of the important effect. Clearly, no problems with inconsistency, irrespective of the I squared. Okay. But and subgroup analysis will so, so you might still, maybe there is a subgroup who doesn't benefit and you might want to look for it. That is still possible. On the other hand, same situation, but now you care about the magnitude of the effect. Maybe there's an important benefit, but maybe there are important harms. And maybe to be really confident, you would like to see a very large effect, something more than the MID. And some of the studies show an important but small effect. Some show a big effect. There, you might want to do a subgroup to explain the variability between the studies that only show small and large effect. That may be important. And then you would want to do the subgroup analysis, and then you would want to use Iceman to decide on the credibility of the subgroup analysis.
Thank you, Gordon. Thank you for your webinar. There is enough. How would you think grade can manage to core grade not to be complicated?
Sorry, I don't understand the question. Can you
Me
help me?
neither. How would you think? The question is in English in the chat, but how would you think grade, not core grade, can manage to core grade not to be complicated? I don't know if it is about tension between grade and core grade.
Um, uh, 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 the way I look at it, there is only one grade. Okay, there's the core grade is completely consistent with all other grade writings. It just says you want to keep it simple and focus on the essentials. You will go to core grade. That is completely consistent with going more complicated. So a core grade is the essentials. It is grade, but it says we can get away without the complications. It's nice to, if you like it, it's nice to get in all the complications of the ETD or all the complications of the different thresholds, but we believe that you will get to the right answer using core grade. So to me, there is no need for attention between the two. It's like in the grocery store, whether you're going to pick one item, which is the cake that is the basic cake, or you're going to pick the cake with more icing and whatever else. Okay. They're both cakes. They're both going to taste good, but you can choose one or the other. It's the same here. Core grade is grade. It is just the essentials of grade. So I do not see that core grade complicates anything. It just gives you a choice to focus. And grade has done this before. So if you look at network meta-analysis, and you want to say we published in the BMJ side by side two different ways of providing grade to network meta-analysis. If you want to use when you're doing the grade certainty of ratings, you can use for network meta-analysis, you can use the cinema tool or you can use grade. They both if they work well, they both get you to the same place. So I think it's a good thing. It's like at the grocery store, you now have an option. They're both, the core grade is grade. It is just the essentials of grade. And you can pick, if you like to focus on the essentials, great. If you like to go and deal with all the more complicated, you can do that. It'll get you to the same place.
Thank you so much, Gordon. Unfortunately, we are run out of time. I'm just putting on the chat the BFJ grade core grade paper for people to have really easy access to them. And I want to
Yvonne,
go ahead.
you can also put in my email if
Yes,
people
sure, right now.
have any questions about core grade.
Got it. I will do it. And thank you so much, Gordon, as usual, for your help, for your support, for taking the time to spend with us. I think it was very important, very interesting for people to know about core grade. And I am just putting your email here for people who wanted to contact you after this. Muchas gracias a todos. Thank you, Gordon.
My pleasure. It was a privilege for me to present to you. I'm very pleased to have done it. Thanks very much.
Thank you, everyone.
Okay.
Muchas gracias a todos. Thank you, Gordon. Bye bye.
Bye for now.